Good evening everyone. Myself Dr. Lekha and I'd like to present about diabetic papillitis, understanding a rare ocular complication. Diabetic papillitis, also known as diabetic papillopathy, is a relatively uncommon but significant ocular complication that occurs in individuals with diabetes mellitus. It affects the optic nerve head, which is crucial for transmitting visual information from retina to the brain. This condition is characterized by inflammation and swelling of the optic disc, resulting in a range of visual disturbances and potential vision loss. As the prevalence of diabetes continues to rise globally, understanding this diabetic papillitis has become increasingly essential. This condition poses unique challenges to healthcare professionals due to its similarities with other optic disc disorders, making the accurate diagnosis and timely intervention crucial to prevent the further complications. A 36-year-old female patient has presented to our OPD department with complaints of diminution of vision in left eye for 1 week, which was sudden in onset and progressive and also associated with headache. Patient is a known case of diabetes mellitus for 9 years and is on regular medication. There was no history of hypertension and cardiovascular disease. Ophthalmic examination revealed best corrected visual acuity in right eye of 6/9 partial and left eye of 6/12. On swinging flashlight test, relative afferent pupillar defect was detected in the left eye. Slit lamp biomicroscopy revealed vitreous liquefaction in the right eye. These were the fundus photographs, and the left eye showed an 2-diopter elevated edematous disc with blurring of all the disc margins, and also both eyes showed moderate non-proliferative diabetic retinopathy changes. Non-contact tonometry revealed IOP of 17.3 in the right eye and 17 mmHg in the left eye. Metabolic workup revealed deranged glucose metabolism with FBS of 192.95 and postprandial blood sugar of 282.09 mg per deciliter. Coming to discussion, diabetic papillitis can be observed in individuals with both type 1 and 2 diabetes mellitus with an estimated incidence of around 0.5%. Although its pathophysiology isn't fully elucidated, it is believed to be associated with diabetic microangiopathy, which finds some support in abnormal disc surface staining and fluorescent leakage observed on fluorescent angiogram. Patients with diabetic papillitis typically exhibit mild degrees of diabetic retinopathy. This suggests that diabetic papillitis is considered a distinct condition rather than being considered merely an extension of diabetic retinopathy. The currently accepted criteria are confirmed diagnosis of diabetes mellitus, optic disc edema, absence of significant optic nerve dysfunction, normal intracranial pressure, and absence of nerve inflammation, infection, or infiltration. Studies have shown that in patients with diabetes who initiate intensive insulin treatment, the incidence of diabetic papillitis has been linked to a failure to downregulate retinal blood flow and a tendency towards increased retinal perfusion. The differential diagnosis includes papilledema, neuroretinitis, infiltrative optic neuropathy, compressive optic neuropathy, AAION and NAION. Coming to management, as of now, there is no established therapy that has been validated for diabetic papillopathy. In most cases, the disc swelling typically resolves spontaneously within 4 to 8 weeks. However, in certain situations, intravitreal corticosteroids or anti-vascular endothelial growth factor therapy might be recommended. Conclusion. In summary, it is essential to consider this diabetic papillopathy as a potential differential diagnosis of papilledema in diabetic patients who exhibit apparent papilledema, but only after diligently ruling out the intracranial pressure increase. Thank you.